Hello, everyone, and thank you for attending today's webinar presenting case studies of 3 Exemplar practice facilitation training programs. My name is Jay Crossan. I'm a senior health researcher with Mathematica Policy Research. And before we begin, I just want to cover a few housekeeping items. You'll notice at the bottom of your audience console are multiple application widgets you can use. You can expand each of the widgets by clicking on the maximize icon on the top right of the widget or by dragging the bottom right corner of the widget panel. If you have any questions for our presenters during the webcast, you can click on the Q&A widget at the bottom and submit your questions. To the right of the Q&A widget is the group chat widget, which can be used to communicate with other attendees during the webcast. Please note that the Q&A panel is for communicating with presenters, while group chat is for communicating only with your fellow audience members. In the resource list widget, you will find PDF versions of the case studies that we will be discussing today, as well as some useful links where you can find more information on practice facilitation and on the programs that we're highlighting today. If you have any technical difficulties while on the call or in the webinar, please click on the Help widget or submit technical questions through the Q&A widget, and someone will address them for you. And at this point, I'll turn it over to Bob McNellis from AHRQ to get us started. Thanks, Bob.
Thanks so much, Jay. Appreciate that great introduction. So welcome, everyone, and thank you for joining us on this webinar today. This is the first in a series of webinars focusing on primary care practice facilitation, and it's brought to you by the Agency for Healthcare Research and Quality in partnership with our colleagues at Mathematica Policy Research. And as Jay mentioned earlier, today we'll be talking about 3 exemplary practice facilitation training programs based on in-depth case studies of each. Also, as Jay mentioned, I'm Bob McNellis, Senior Advisor for Primary Care at AHRQ, and it's my pleasure to welcome you. I'll provide a few brief introductory remarks and then get out of the way for our case study authors and their special guests. But if you don't mind, let me just spend a moment talking about AHRQ and our perspective on practice facilitation and why we think it's so important. So next slide, please, Hannah. AHRQ's mission is to produce evidence to make healthcare safer, of higher quality, more accessible, equitable, and affordable. And we strive to partner with others to make sure that evidence is understood and used. Consistent with that mission is AHRQ's belief that primary care is the foundation for a healthcare system that delivers safe, high-quality, accessible, equitable, and affordable care. To that end, AHRQ has invested in research to help us understand the best approaches to support primary care practices as they transition from older models of care delivery to newer models that emphasize better patient outcomes, better experiences of care for patients and clinicians, and help lower costs. It's clear that many primary care practices, especially smaller practices, need some sort of external infrastructure to support practice transformation and quality improvement. We see practice facilitation as one evidence-based strategy to assist practices as they move to new models, like the patient-centered medical home, and can facilitate ongoing quality improvement efforts needed to make these substantive changes. Let me give you a quick plug. AHRQ has white papers, briefs, and other resources on these issues and others at our PCMH Resource Center at pcmh.ahrq.gov. Next slide. And I hope you're not surprised that AHRQ's support of practice facilitation is not new. We have products dating back at least to 2009, integral to our support of the chronic care model. 2 specific products on this list I want to highlight for you. And first is the how-to guide to developing and running a practice facilitation program and the practice facilitation handbook. Both of these are available on the web, and you can see the links there. We think they have great value to you, our audience. In fact, we continue to build on this work together with our colleagues at Mathematica and experts in the field. We're developing a competency-based practice facilitation model curriculum. In addition, as you can see, we've funded dissemination and implementation projects that rely on the important work of practice facilitators, including our impact grants and our most recent grant opportunity to implement P-Corps findings into primary care practice. That'll be awarded early next year. So it's clear to us that we need a strong practice facilitation workforce to support these efforts. So next slide. With that very quick overview, let's talk about what we're going to do today. Here's the agenda for the webinar. We'll spend some time on each case study. We'll hear from the experts at these programs, and perhaps most importantly, we'll have some time for questions from you. Next slide. Lastly, we just want to give you a glimpse of here are the people you're going to hear from today. You'll hear more about them and from them later in the program. And with that brief introduction, I'm going to turn it back over to my partner at Mathematica, Jay Crossan. Jay, take it away.
Thanks, Bob. Next slide, Hannah. So as many of you are probably familiar with this definition, but I'll just set the ground for what we're talking about in terms of practice facilitators today by defining what a practice facilitator is. Practice facilitators are specially trained individuals who work with primary care practices to make meaningful changes designed to improve patients' outcomes. They help physicians and improvement teams develop the skills they need to adapt clinical evidence to the specific circumstance of their practice environment. Today we're going to hear about 3 programs that are currently providing training for these sorts of individuals. And for the first of these presentations, I'll turn it over to Lindy Knox from the LANet Practice-Based Research Network. Lindy?
Thank you very much, Jay. I'm very happy to have the opportunity to talk with the audience today about the North Carolina case study. First, I want to tell you a little bit about myself. I'm director of LANet, which is a practice-based research network in Los Angeles. And we provide practice facilitation predominantly to safety net practices in the county. But we also have been working very closely with Mathematica and AHRQ on what I call the study of the care and feeding of practice facilitators. And so it gives me a lot of pleasure to be able to talk about the work that Anne Lefebvre and her team have been doing in North Carolina. We did a case study about their overall program about 1.5 years ago, and this particular case study is focusing on training and how she's gone about training her practice facilitators. So the first thing I'm going to do is give you a brief overview of the case study, and then I'm going to invite Anne to actually have a discussion with me and answer a few questions about her training program. So to give you just a quick background about her program, it was started as a 2 practice facilitator demonstration project. It was part of the Robert Wood Johnson Foundation's Improving Performance for Practice program. It was so successful as a demonstration project that state policymakers wanted to expand it statewide and provided some recurring state funding to do so. This happened in 2008. But this created an enormous challenge for Anne and her team, and at that point I think it was Anne and maybe one other person, in how do you scale up from a 2 practice facilitator demonstration program to a workforce that's capable of supporting an entire state that includes 100 different counties. Next slide, please. So now I'm going to shift and talk a little bit about how Anne and her team went about doing this and specifically about their training program. The training program that is run by the North Carolina AHEC Practice Support Program is only for its practice facilitation staff. So it's not one that's open right now to outside students. The background of the people that they're hiring in as practice facilitators that go through this training come from a wide variety of backgrounds. They have MPHs, many are RNs, Masters in Health Administration. A fair proportion of them are also second career people, and so they bring prior experience from a variety of different healthcare settings, which Anne and her team are able to leverage not only to support the practices, but also as faculty and support for their training program. And then one of the things that is very important in terms of the hires for these positions is that they've had some previous experience in ambulatory care. Next slide, please. So one of the things that Anne and her team set about doing when they were developing a training program to really develop a brand new workforce for the state was to define the different competencies that these practice facilitators needed to have. And there's 6 different categories. You can see them here. But what I think is very exciting about the way Anne and her team run their training program is it's very organic. So the competencies list is changing and evolves over time based on emergent needs in the field or new events like the coming online of the Meaningful Use Stage 2, So it's not a hard and fast static set of competencies. Another thing that I've found very interesting about Anne's program is how they define levels of competency. And not every skill that they list that a practice facilitator needs to have requires a level 4 competency. And this model is actually something that we've adopted out at LANet as well. And so it introduces some nuance into what you need to do to prepare a practice facilitator to be able to go out into the field. And so you can see here the 4 different levels. Some skills are going to require level 1 from the facilitators. Some are going to require level 4. And she has a very nice, if we can go on to the next slide, a very nice way of starting the training program. So now I want to talk a little bit about the different methods that Anne and her team use to train their facilitators. And so the very first step in their training program is for the facilitators to complete a self-assessment of their level of competency. And you'll see here a screenshot of that assessment tool, and it's actually a copy of it's included in the case study. And it designates for each competency the level that that practice facilitator should have obtained with that particular skill or knowledge base or competency. Next slide. And just one more comment about that initial first step of the assessment is that assessment is also conducted annually, so the facilitators are expected to complete it annually, and then Anne and her team use that to guide what they're going to do in the training program in the coming year to fill gaps in the facilitator knowledge, as well as the facilitators are expected to have a level of professionalism and take responsibility for acquiring those competencies as well. So a second component of our training program is continuous training, and one of the things Anne emphasized over and over, and I can't agree with more, is it's not a one and you're done. So the training is continuous, it's evolving. She has twice yearly team building training sessions that are in person, so she brings people from all across the state because these facilitators, and it's important to note that her facilitation is done in teams. So each team has a QI coach, it has an HIT expert, and it oftentimes has a data expert attached to it. So they come together twice yearly in person for training, sharing ideas, and team building. And then she holds bi-weekly virtual trainings that everybody also attends. They just basically teleconference in from wherever they are in the state. And then also has something that she calls office hours. And so if there's emergent needs in the field, facilitators can ask and call into the director's office and say, we need training on this, and they will have a special virtual training to bring facilitators up to speed on that. The third component is this listserv, and this was also a very exciting piece which we're implementing at LANet as well, is the listserv is a very useful and central tool to their training. There's up to 20 posts a day. Facilitators from across the state communicate with each other on a daily basis with it. They ask each other questions. They share resources. Anne and her team track the chatter on the listserv to know kind of what's going on out in the field and where there may be problems. And then they have a librarian that actually catalogs these posts, and it becomes a growing knowledge base for the program. The final component of the training are tandem site visits, and this is also very innovative. When Anne was starting to build this workforce, she actually hired the facilitators from the area and then trained them in the actual practices that they would eventually support themselves. Next slide, please. So to talk just very briefly about outcomes, they've trained over 70 facilitators at this point. They have teams supporting more than 1,100 practices across the state. And every AHEC region, there's 9 in the state, have a team of facilitators to provide support to its practices. Next slide, please. So one of the compliments but also challenges of this particular, how effective they've been in training these folks is Anne now struggles with people hiring away her facilitators. So health plans, integrated health systems, and other groups have been interested in hiring and oftentimes do hire her staff to go and work for them because they're so highly skilled. Next slide, please. So now I'd like to ask Anne to join me. And Anne, I have just a couple of questions for you. Are you there?
I am.
Great. Excellent. So Anne, thank you again so much because she spent countless hours with me interviewing her, and I had the great opportunity to learn from her experience. And she's very modest, and points out that a lot of her work, we were laughing yesterday, is emergent design, which consists sometimes of making it up as you go along. And there was another one you introduced to me, Anne. What was it called? Immersion crystallization?
Immersion crystallization. So I call these things
thinking hard about something. Yeah.
Thinking really hard about things, or we did it the best we could at the time. Those types of things.
Excellent. So we have probably about 5 to 6 minutes for me to ask you a couple of questions. And the first question I want to ask you, Anne, is to talk to me and the audience a little bit about how you decided and defined those competencies and skills that your practice facilitators needed to be trained up in.
Well, it's a little bit chicken and egg, really, in developing the competencies, because a lot of the competencies are really guided by what those staff out in the field tell me they need. Our entire program, the success of the program is based entirely off of the practice facilitation staff. These are incredibly motivated people who want to go out and help these practices. And in doing so, they don't like it when they get into a practice and they don't have the information that they need. Or as they hear of new policy changes coming on, it's really the staff who drive the competencies. In addition to that, I have to be honest, some of it is guided by funding organizations. So if we receive a new grant when we started this strictly in really clinical improvement and working in disease categories, and learned very quickly that we had an EHR problem. So we started to really gain knowledge in how to work in EHRs, and at that time then we were awarded the Regional Extension Center grant. And so we definitely had to come up to speed on meaningful use and all of the qualifications, the certifications that vendors need, plus what is meaningful use. And now that leads right into PQRS, too. And so some of it depends on what are we paid to do to help the practices out there, but then the rest of it, probably the bulk of it, really relies on the staff feeding back to me, what do they want to learn, and how can I find the resources to support them?
So, Anne, talk to me just a little bit, because this is something we've struggled with at LANet as well, is how do you balance kind of these general skills, like how do you run meetings and how do you get people to work well together in practice improvement, and then the deep technical skills that they need, for example, to produce meaningful use reports out of an EHR? Because I think you've been particularly effective in kind of finding a balance between those two sets of competencies.
Yeah, I mean, I think this too is, austerity creates an enormous amount of innovation and creativity. And so first of all, it's not realistic to expect one person to be an expert in every single one of these I think, actually, I hadn't counted them until I started working with you. I think you said we have 49, I think. And so I certainly can't expect to hire someone with expert level in all of those areas, and I certainly can't expect someone to come in and just have that breadth of expertise. And so really it's helping our teams work within themselves and really learn how to use each other. Sometimes if one team doesn't have a specific skill, we can reach, because we're all one organization, we can reach over to another team in another region of the state and use their skills. And so in some ways, it's simply because there's just too much to know and there's too much to do, and the more effective they can be at using each other's skill sets, and then they learn from each other. So if I have to pull in another person today to help me pull this data out of a specific EHR, next time I might be willing to try that myself, but give this other person on my team a heads up that I might be calling them. And so I think it's a matter of using our team members and the skills and expertise that they bring to the program and making sure everybody's kind of used to their highest level, and then making sure that they feel free to learn from each other and try it out and have the confidence and empowerment to do so.
Right, that's excellent. I just want to take a moment. I know that there's questions coming in from the audience, and we will have a time after all 3 case studies have been presented for kind of an open forum, and we'll be pulling your questions at that point. So don't think we're ignoring you. Anne, I want to ask you one more question, and then we'll move on to the next case study. I was particularly struck with the challenge of going from 2 practice facilitators to a statewide workforce, and kind of how you went about solving that problem. And I was hoping you might describe that for the audience, because I'm sure there's a number of participants that are facing similar challenges. And I thought the way you went about doing it was particularly innovative and reflected a lot of really good immersion crystallization. So could you please talk about that, and then maybe some of your lessons learned that you might want to share with the audience about that kind of scale-up?
Sure. So again, this is done in the only way I could figure out how to do it at the time, and that's about as much investigation as we could put it in. So this was back in 2007, 2008, when we had great colleagues in Colorado that we were working with at HealthTeamWorks, and we were trying to figure this out together, but there weren't a whole lot of places doing this at the time. And so I had to go, I have 9 regions in the state. I had to go from having 2 regions up to 9 regions covered across the state, and that meant that I had 7 people that I had to bring on all at once. And even at that time, it only gave me 1 person in each region, which we all know really isn't enough. And so what I did was I myself was a QI coach. I myself was a practice facilitator. And so I would go into a region. I would, I guess what we would say, beat the drums or drum up some business. I'd work with our partners at Community Care of North Carolina to get practices who wanted to work with me on this. Then we would hire the practice facilitator. The practice facilitators have to come on with practices to work in. And so I would go to one region, bring on about 10 practices, hire a practice facilitator, get that practice facilitator comfortable doing tandem visits with me in that region, and then I would come out and support them by phone calls and emails and occasional visits and move to the next region and bring on 10 practices. So we joke, at one point I think I was carrying about, 300 practices in our state because I was doing 10 per region as I went across the state.
Excellent. Well, Ann, thank you so much for that sharing, and we'll have a chance, the audience will have a chance to ask you some more questions a little later in this session. But right now I'd like to pass the baton back to Jay for a quick wrap-up and then moving on to the next case study.
All right, thanks to both of you, and we'll move on to the next case study, which is of the Millard Fillmore College Practice Facilitators Certificate Program, and Dana Peterson from Mathematical Policy Research will lead the presentation. Dana?
Yep, thank you, Jay, and I'm glad to be here this morning from Oakland, California. And I'm a senior researcher at Mathematica Policy Research, and after my kind of high-level overview of the Millard Fillmore College Practice Facilitator Certificate Program case study, I'll be joined by June Levine, who is the instructor from the course to answer some questions. So first I just want to say that this program is an online distance learning course that offers certification to participating students, and it's open to the public nationwide. Thanks, Hannah. So as background, this program began as a project of the Coalition for Coordinated Networks, which is called CocoNet2. And this is a group of 6 primary care practice-based research networks that was funded a few years ago by AHRQ in 2012, kind of to develop and think about innovative strategies for accelerating QI in primary care. And one of the ideas they came up with was this kind of training. So members of CocoNet2 routinely work with practice facilitators, each training their own staff, and they saw a benefit to developing a standardized training program that would allow them to leverage each other's expertise and take advantage of economies of scale. They also expected that this kind of training program would be important for meeting the growing demand for PF as we continue with ongoing health reform. So the group drew heavily upon the modules of AHRQ's Practice Facilitation Handbook that was mentioned by Bob earlier with the link on an earlier slide when developing the content for their training. And this handbook was originally co-developed by AHRQ staff and a member of CocoNet2. So then Millard Fillmore hired on an instructional design assistant to help them transform those materials from a print resource to an online resource. At the same time, there was another member of CocoNet2 who was faculty at SUNY Buffalo's Department of Family Medicine. And he had conversations and encouraged the dean, the associate dean at Millard Fillmore, which is SUNY's College for Continuing Education and Support, to house the program because he thought having that online course housed at a university would give the program much more credibility. The associate dean there agreed to this idea because he saw the intent of the training course or certificate program matching the mission of the college, which is to help professionals start and build careers. And the college was also uniquely interested in being one of the first to offer university-based PF training and certificate programs in a job market that they saw, expanding rapidly in the future. So the first pilot course was offered in the summer of 2013, and it's been followed by 2 others since. Next slide. So the high-level goals of the program, the Millard Fillmore Certificate Training Program, are to provide high-quality and standardized training for practice facilitators that teaches the core competencies of the work and to offer this kind of certification to those who complete the course as a marker of recognition. The course also strives to build a nationwide network of PFs by connecting current students and graduates via a learning community. So thus far, the majority of students who have enrolled in the course have had experience working in healthcare settings and have included physicians, healthcare administration staff, nurses, and PFs who want more training or certification. So many of the students have come from university or community-based, practice-based research networks, and some have come from individual or group medical practices and even some from community clinics. Host organizations or practices commonly, thus far anyway, have been paying the tuition on behalf of students as a professional development investment for their ongoing work with their host organizations. Next slide. So the instructor, June, who we'll be talking to in a few minutes, generally and often adapts the curriculum for each course offering based on the makeup of the students in the particular group, their strengths and desires for areas of growth, and on what's new and emerging in the field. Students, when they start the course, fill out a professional development plan, and June uses this information to make content decisions. Generally, the course begins with developing students' understanding of the role of PF and the contributions that PFs can make to a medical practice. Students learn the common elements of the facilitation process, basic elements for working with medical practices, and tactics for introducing and preparing practices to work with the facilitator. QI topics and skills covered generally in the course include workflow mapping and redesign, plan-do-study act cycles, root cause analysis, academic detailing, and developing and implementing QI plans. Specific measurement skills included in the course include selecting and developing measures, conducting readiness and organizational assessments, measuring and benchmarking clinical and organizational performance, conducting chart audits, and preparing and presenting data. There are also specialized skills and topics covered in the course, such as team building and meeting facilitation, implementing the chronic care and medical home models, understanding population management, registries, and team-based care, understanding electronic health records and meaningful use, and tracking progress and outcomes of practice facilitation services. Next slide. The structure of the course, this online course, is that it consists of 13 90-minute online seminars. Then these seminars include lectures by the instructor, guest presentations by experts, and virtual group discussions among the student participants. And the course is paired with a supervised field component. So students link to the course platform from their own computers to participate in the class sessions from wherever they might be across the country. They use this platform to view presentations and materials, do their homework, participate in discussion boards, and interact with the instructor and other students in real time. The course has rigor in that there are assigned and required assignments, including pre-session reading, homework on PDSA cycles and workflow mapping. There's required participation in some online discussion boards, and each student is required to submit reflection journals weekly that discuss their response to readings and their participation in the field component if they're doing that. The course includes this preceptorship that I've been talking about that requires completion of a 40-hour field experience. These have to take place at approved sites, and these sites provide students with hands-on practice that further builds their knowledge and skills. The students enrolled in the online course can either do their field experience concurrently while they're enrolled in the 13-week session, or they can do it sometime soon after completion of the course, depending on their physical location. The course takes a shared approach to learning in which the instructor and the students learn from one another. It follows adult learning principles and tries to make the content relevant to students' professional and personal experiences and invites students to continually reflect and share upon those experiences in the class and in their journals. Next slide. So to date, there have been 28 students who have graduated from the course and received their practice facilitation certificates from Millard Fillmore. Currently, there are about 15 more students that are finishing up the third offering of the course, and they should be complete and considered graduates with their certificates in hand by the end of the summer. Since most of the students who have taken the course thus far have done so under the auspices of their employers or host organizations or medical practices, and the tuition has been paid for by those programs, they've continued to work at those entities after completing the program. In many cases, this is expected because the employer has subsidized or paid the tuition. Next slide. So now I'm just going to kind of give you, in developing the case study, I talked to some of the, training developers, some of the administrators at both SUNY Buffalo and at Millard Fillmore. I talked to June and also a student who had completed the course, and a number of kind of lessons learned relevant to others who might be interested in developing or are currently delivering training programs can be distilled. The full list of these is available on the case study that you can find on the AHRQ website, as Bob described earlier. But I'm going to just kind of briefly describe a few here and then transfer to June to answer some questions. So first, what's interesting about the Millard Fillmore program is that they really were able to capitalize on some strong existing relationships between SUNY Buffalo and the Department of Family Medicine and the Millard Fillmore College. They were also able to build on the expertise and the past experience of the CocoNet 2 members in their past projects with AHRQ. And these relationships and resources were really instrumental in developing the program. A key resource there was the AHRQ handbook, which was developed by a CocoNet 2 member together with AHRQ, and this provided a well-formulated structure for the content of the program. Additionally, involving an instructional design professional was very important in transforming those print materials into an online, interactive course. And this instructional design professional had expertise in online learning, technology, and adult learning. Also interesting about the Millard Fillmore program is really this joining of the online and field experiences, requiring students to complete a fieldwork component under supervision of a more experienced practice facilitators really enables them to apply course content and further builds their knowledge. And finally, in an online course like this, instructors must not only have significant subject matter expertise and general teaching experience, but also experience in online pedagogy. They have to be familiar with technology and particularly skilled at encouraging dialogue and maintaining a high level of student interaction in the online environment. And Millard Fillmore has been exceptionally lucky in being able to find and use June Levine in this role. So now, Hannah, next slide. If I could, I'm going to introduce June Levine, who is joining us today. And she is going to tell us a little bit more. I have a couple questions for June, and then as Lindy noted, we're accepting questions through the online Q&A feature, and June will be available to answer additional questions about the Millard Fillmore Certificate Program at the end of our presentation. So thank you, June, for spending time with me to develop this case study and reviewing drafts, and for being here to talk with us today.
Thank you.
Are you there, June?
I am. How are you?
Good morning. I'm good. Good morning. I know you're also in California with me. So my first question for you today is what lessons have you learned that are specific to running and developing a training program virtually, as I know you've done both classroom and online training. What are the upsides and downsides of running a training program in a virtual environment?
Thanks for asking the question that lots of people ask. So I wanted to highlight two things that really have been overriding from the very beginning. And the two primary areas relate to technology and relate to engagement of the students. So we were aware that the potential was there from the beginning of having some technology issues. So one of the things that we developed was a video for the students once they had been registered through Millard Fillmore, that they could actually then use the video to sort of understand two different platforms. One was the platform that we use in the college to actually do all of their assignments, where they post all of their information, and the other really is the platform that we use during the hour-and-a-half engagements every week. And we definitely had issues at the beginning, in particular with the online platform on the weekly class our technology, actually our instructional design person was extremely helpful, and we found it very useful at the beginning to actually have this individual online with us every single week for that first pilot. By doing that, we were really able to mitigate and or eliminate some of the issues that were just there. And often we were able to facilitate with the student some ways to help without interrupting the flow of the course. We also, some students can, and we learned this quickly, needed to be able to access us through either the online, through the computer, or the separate call-in phone number. And we encourage the students to keep that number with them if they could not get online. So put it in their iPhone, keep it on a piece of paper, near their desk, wherever they were doing the program. In the third cohort, we do not have an instructional design person available. We have not had a problem with it. What we find now is there are issues, and they really relate mostly to the student's computer and their inability really to use the audio effectively. They'll go in and out. They won't be able to get online with their audio. And so, again, we do have to consistently remind them about the phone call-in structure, which should help. So that's sort of technology in a nutshell. The engagement part is perhaps, from my point of view, one of the most significant, and certainly can be one of the most difficult parts of running any kind of virtual class. We've used different technologies to help and different strategies, and so I'll just mention a couple. We're using Collaborate as our online methodology when we do the weekly sessions. And one of the advantages is it gives us a chance to do polling, which means that I can ask a question and the students can show yes or no by clicking a button. And so then we have sort of established some community, and we can use that information. I can use it as an instructor to, emphasize or de-emphasize certain strategies, change them a little as we're going through the course, and the students themselves get to understand what their peers are doing, where their peers are, have some strengths and some needs for their own growth and development. The other strategy we've used is I've incorporated questions into my slides, and the students get very quickly the fact that when I pose these questions, they're supposed to respond. So it helps paying attention. We provide the PowerPoints ahead of time. So, for example, if a student needs to print them off and won't be at their computer and are just going to be on the phone, they can have them available. But they answer those questions. And the other thing that I've learned about engagement is sometimes, and I know if any of you have done this, you've definitely experienced this quiet, this silence that goes on, and you think, are they listening? And so I'll stop and I'll say, so does any of you have any questions? And then I still get silence. And so I literally ask any student that has not responded or has not asked a question or made a comment during the prior discussion, I'll just say, so Linda, what do you think? Have you had experience in this? And I think to their credit, they have really responded. And they understand that this is an interactive type of platform. And so those are some of the things that I've done to encourage them and keep trying to figure out new strategies and new ways, because it's really an important part of their learning and my ability to be effective.
That's great, June. Do you also, is there a video, unlike the webinar we're doing today, is there a video component to your online platform? Are they seeing you talk in real time?
Absolutely, and thanks for mentioning that, Dana. I sort of lost that in my own translation. The interesting fact is they all can click on a video component. They can all then be seen by all of us whenever they're speaking. However, it's been an option. And so there are students who actually do click on. I'm on it all the time so they can see me. But we've had too many students either not able to click on a video component for whatever in their own computer, they're just not linking well, or they choose not to. So one of my learnings is that I'm going to be a little more encouraging from the beginning because I think it's helpful and a really excellent strategy. Thanks for mentioning that.
No, thanks, June. The next question I have for you is about the preceptorship that is part of the Millard Fillmore certificate program. So how do you as the instructor or Millard Fillmore as the college hosting the program support that field experience for students, and kind of how does that complement the virtual group training that you offer?
I think the preceptorship is critical, and I've been an advocate from it from the beginning, and we developed some strategies. Where the student gets the preceptorship is probably one of the most difficult questions. Where are they going to be tied into someone who understands how to precept and who understands how to help the student? So one of the things that we've done is no matter where they do their preceptorship, I'll link with the preceptor, make sure they understand what the course is, provide them the overview of the course so they can see it, answer some of their questions, and often literally make suggestions, knowing the student, knowing the place that the student is going, to try to give this individual, the preceptor, some ideas about how they might help and assist the student in getting some different experiences to build on the needs of the student. I encourage the students to think about this and to actually work with the preceptor to design their 40 hours in a way where it's a growth experience and not just repetitive. We've been very successful. There are many preceptors who I'll talk with on the phone, and it's clear they already know how they're going to approach it. They've had experience doing it, and all I'm doing is sort of listening to ensure that it will be a positive experience for the student. They do their preceptorship. Actually, we've come out with 3 different opportunity strategies. One is to go to a site like the University of Buffalo or LA-NET, where Lindy is, to actually work with people who are practice facilitators, who understand the role, and who are very adept at providing those growth experiences. So we have that strategy. And if the student is close enough or wants to travel, then that option is open. The second option has to do with the student actually doing the preceptorship within their own organization. Many of us who've worked in particularly large organizations sometimes have a role that's fairly, I always like to say, sort of has a box around it, so that I'm aware of this other stuff in the organization going on, but I really don't know about it. I really don't have a chance to link to it, and maybe even understand how much learning I could gain by just interacting with some of the individuals involved with those different aspects. So in some organizations, we've had that experience where I've spoken with the preceptor, and the student has really gained a lot from going in depth in another area, sort of right at home, but very distinctly different from what they've been doing, sort of a building exercise. The other piece is actually to connect them with certain community organizations that will provide them experiences, again, that they had not thought about, had no opportunity to link with. A good example is a QIO or the primary care organization that might be within their area. There are many community groups that could really provide the practice facilitators with eyes into the community in areas that we don't talk about extensively, or perhaps that particular student, for whatever their project, their focus of their own practice, could really benefit much more from. So we give them those different opportunities, And I think that particular area of the community piece is really growing. And one of the challenges to me is learning early where the student is located and what's available in their community so that we can get them started earlier in doing it. Dana, as you said, we do enable the student to either do the field experience during their course, and in some, the practices they're in have been so accommodating and supportive of these students that they'll give them some extra time or time away from their regular activities to do that work. Sometimes the student is actually traveling, or they want to spend an entire week sort of in an immersion kind of way, and so that will occur at the end. And I track that. The other component that we've done to even engage the preceptors is we ask the preceptor to fill out a form at the end, not just attesting to the students' hours, but also answering sort of on a Likert scale how well the student has learned certain types of competencies that we've detailed out. And we also give the student the same opportunity to answer that same questionnaire so that we can compare them and see where some of the preceptorship has really benefited the student in their own growth experience. So I hope that answers the question. I'd be certainly open at any point to answer further at the later part of the program. Thanks for asking.
Thank you, June. That really does help a lot. That sounds like a lot of individual work on the part of you as an instructor to get students in the right place. And we do, as Lindy said, have time later in the presentation to answer some more questions that have been submitted by the audience. So with that, I think I'll pass it back to Jay, who will introduce the third case study.
Great. Thank you, June and Dana, for all that great information about the Millard Fillmore program. And I just want to point out that we've gotten a lot of great questions already, and I encourage you to keep them coming. We're not ignoring them. We're getting them ready for the Q&A session coming up soon. And now I'm going to turn it over to Tricia Higgins from Mathematical Policy Research, who's going to talk about the HealthTeamWorks Coach University program in Colorado. Tricia?
Great. Thanks so much, Jay. As Jay said, this is Tricia Higgins. I'm a senior researcher at Mathematica. Next slide, please, Hannah. Thanks. So Coach U is the name of the practice facilitation training program run by HealthTeamWorks, which is a nonprofit organization located in Lakewood, Colorado, just outside of Denver. HealthTeamWorks has offered coaching services since 2006, and initially they offered direct coaching services, which involved having a trained facilitator from HealthTeamWorks go into primary care practices in Colorado to work with their staff. But eventually the organization shifted to a more collaborative coaching model in order to help practices sustain practice transformation after HealthTeamWorks staff left a particular practice, and they've also expanded to work with practices across the country. This collaborative coaching model was centered around a new PF training program called Coach U, which has been operating since 2010. As part of Coach U, organizations send their own staff members to a week-long boot camp. And after completing boot camp, the trainees have access to a year of individualized support from HealthTeamWorks coaches and staff. Next slide, please. The goals of Coach U are to achieve sustainable practice transformation by teaching key people within healthcare organizations to facilitate continuous quality improvement and to teach technical skills, change management, and relationship building skills. Trainees' employers contract with HealthTeamWorks to provide assistance with practice transformation activities, and sending a staff member to Coach U is part of that contract that employers have with HealthTeamWorks. HealthTeamWorks clients include groups such as accountable care organizations, medical societies, residency programs, hospital groups that have purchased ambulatory care facilities, healthcare systems, and individual practices. And trainees themselves have a broad diversity of backgrounds and varied levels of experience with practice facilitation. So they include nurses, physicians, individuals with doctorates, masters, and bachelor degrees. Next slide, please. HealthTeamWorks leaders consider the joint principles of the patient-centered medical home, along with other quality improvement methods, to be foundational subjects taught during Coach U. Within this broad subject area, key topics include care coordination, care management, population management, and use of evidence-based guidelines. And then other areas of focus vary by client needs. For instance, HealthTeamWorks incorporated information on behavioral health integration when it began working with trainees from a large behavioral health plan. In addition to deepening their knowledge in these foundational subjects, Coach U participants also undergo training in technical and interpersonal skills necessary for their work, such as effective meeting facilitation, problem solving, extracting data from health IT systems, using these data for quality improvement, conducting practice assessments, and engaging in process improvement. Next slide, please. Coach U begins with a one-week boot camp, which is offered 3 to 4 times a year, in which 6 to 15 trainees gather for intensive in-person training. Boot camp includes classroom instruction along with visits to practices to observe and participate in real-world applications of lessons. Within the classroom, faculty members who are all experienced practice facilitators themselves use a mix of direct instruction and experiential approaches such as role-playing. During visits to practices, trainees shadow a HealthTeamWorks coach as he or she works with the practice on transformation activities. Trainees are able to observe and assess various quality improvement processes being used within the practice. After boot camp concludes, all trainees continue to receive some level of support throughout the year, which varies by the particular needs of the trainee. Next slide, please. Since August 2010, more than 100 trainees have completed boot camp. Trainees return to their organizations after boot camp and work to develop and implement practice transformation goals. And just to give you a sense of where the trainees tend to work, about half of them work as coaches in large health systems, and then there are smaller numbers working in federally qualified health centers, accountable care organizations, various grant-funded practice facilitation programs in Colorado, medical societies, educational institutions, or medical residency programs. Next slide, please. HealthTeamWorks provided many valuable lessons learned, and I would encourage all of you to check out the full case study to see them all. But here are just a few. First, knowledge of patient-centered medical home components, quality improvement techniques, and related core competencies is crucial to practice facilitation. But skills such as meeting facilitation, encouraging buy-in to an idea or process, and motivating people to achieve practice transformation goals are just as important. In addition, learning how to help practices adapt to multiple simultaneous complex changes, which can be overwhelming, is an important component of practice facilitator training. Second, real-world experience shared by faculty within the classroom setting helps trainees absorb the content and process the content in a way that makes it easier to apply later on. In addition, HealthTeamWorks continuously gathers suggestions from trainees and clients in order to adapt the content of the curriculum to reflect new topics of interest in policy and industry. And finally, HealthTeamWorks leaders note that Coach U trainees appreciate both direct instruction and the ability to engage in activities and exercises that help them apply their knowledge and develop their relationship building and change management skills necessary to do their work well. Next slide, please. We're happy to have Kelly Boland joining us from HealthTeamWorks. Kelly is the HealthTeamWorks Education and Training Manager and a QI coach. Kelly, thanks so much for joining us today.
My pleasure.
And we'd like to hear your thoughts on a couple of questions. The first question I have for you is, how have the competencies and skills you covered during boot camp evolved over time?
Well, thanks, Tricia. We started out with the elements of the patient-centered medical home, as you had mentioned on your previous slides. And that was great, and it was a good start, but then all of a sudden the market started changing, and we got requests for different items. And just lately it's been the behavioral health integration, and how is that going to work from both sides, whether you're a behavioral health clinic or you're a primary care clinic. So we've added a whole 1-hour class for that. And then just last week when we had our last Coach University, we went to a behavioral health clinic that was integrated, and we think that that's where it's going. But the other topics, payment reform always comes up. What's the latest, greatest things we need to know about that? Data, how can you work with several different kinds of EHR? So we basically listen to our clients, listen to the Coach U participants, and then modify our content based on that as we go forward. We're also noticing that 3 years ago when coaches came to Coach University, they had minimal knowledge. Now people who are coming just even last week, their level of knowledge about practice facilitation is a lot more. So we'll start at a higher level, so we don't have to do as many of the basics now. So again, it's based on what the client's needs are and what the market is demanding.
Great. Thanks so much, Kelly. And my second question is, when you send your trainees into primary care practices to shadow coaches during boot camp, what types of knowledge and skills are you hoping they gain?
Well, there's about 4 different things that we hope to gain from that. Number one is once you've seen a practice, you've seen one practice. Basically, that recognizes that every practice is unique, but they're very similar. And we as coaches have to always recognize that there's dynamics, there's culture, there's change going on in every practice, and you need to be available and adaptable to what their needs are. The second thing, I think, is that you have to be yourself, and you have to develop your own coaching style and use your own strengths and recognize what your weaknesses are and ask for help and resources to fill those needs. The third would be you need to be prepared but flexible. And what I mean by that is that we want to encourage practices to use agendas and get them to you ahead of time, and, things happen. And, for example, a couple weeks ago I went to a practice, and they were like, we just found out from our system that we're going to a new electronic health record in 2 weeks. And so that, threw our agenda out the window, and we worked on what they needed to work on, and here we'll get them back on track in a couple weeks. And I think the final thing that you really need to do, and we hope that we gain from them going to practice, is focus on the deliverables of the program or initiative you're working on, because it's so tough when you're in practices and there's so many demands and priorities from everybody and outside entities that it's hard to keep them moving on the deliverables of whatever program you're there for. And so you have to keep continually focusing on it and working 2 or 3 steps ahead of the practice to keep them focused on achieving those goals.
Great. Great. Thank you so much, Kelly. And again, I would encourage everyone to check out the HealthTeamWorks case study online for a lot more wonderful information, as well as the other 2 case studies. And now I'll turn it back over to Jay.
Great. Thanks, Tricia and Kelly. And we'll move on to the part of the program where we're going to get your questions addressed. And I really want to thank everybody for sending in all the great questions so far. And you can keep them coming, and we'll get to just as many as we possibly can in the time that we have. And ones that we don't get to today, we're going to also address in future editions of the Primary Care Practice Facilitation electronic newsletter. And there's information about how to sign up for that newsletter in one of the widgets at the bottom of your screen there. So with that, I will turn it over to Lindy, who will facilitate this portion of the webinar and route the questions out to the speakers to get some answers to what you've asked already. Lindy?
Great, Jay. Thank you so much. And so the first thing I'd like to do before we move into the submitted questions, are you guys hearing me okay? I'm getting some feedback. Is it all right? Jay, can you hear me?
Yes, we can hear you.
Okay. So the first one is really for all of our speakers today, our directors of programs. And the question is, and it's a big question, is what do you see the practice facilitator field needing in the next 12 to 24 months? For example, if you had a magic wand and you could create anything you wanted about practice facilitator training, what would you develop? And Anne, let me ask you if you would open the conversation.
This is a good question. I think one of the challenging things, at least for our program, is we need some policy decisions made, please. So it's very hard to help a practice achieve programs that may be on hold or may be going forward or may be changing. And I think, and so this is, I know I'm asking for something that I can't be given, but I think we can help these practices tremendously, and we can really improve care with this type of model for delivery. But we can only do it as well as we have guidance. And so I think we've come a long way in the last 5 years or so. The whole process for nationally endorsed measure sets and those types of things has really come a long way to help this type of work. But now I think some tough decisions need to be made about are we using CQMs? Are we using PQRS? Are we sticking with these measures? Or how are we going to handle evidence-based guideline changes? So clinical impact versus are we going to keep measuring this even though physicians don't agree with the care that it's providing? So I think we're in a really great place, but I think some of our work is held up because we don't have a process for decision making on some of these larger policy issues in this country yet.
Great, Anne. Thank you for that. Important answer, I think. Very much so. So June or Kelly, could you also weigh in? If you had a magic wand, what does the practice facilitation field need in the next 2 years?
Lindy, this is June. I really love the question. And while Anne was talking, I was thinking about my answer. And I think it's one thing. When I think about all of the topics that are included in the programs, I think about the lack of many of these topics within the health professional educational programs. And I think that the issues of leadership, of team building, of how to even run a basic meeting and dealing with outcomes, clinical and non-clinical, are something that is not often a part of medical, nursing, public health, healthcare administration courses, where these people are now going into the professional settings and doing their work. And it is something that I think is lacking. And so what I would like to see is some alliance with the academic programs and some of the work being done around the country with the groups that you've heard today and others who might be also looking at some of this to actually support those academic systems so that these students who now are the professionals of tomorrow will have the skills that healthcare really needs to go forward.
So June, you're talking about integrating this curriculum into schools of nursing, medical schools, public health schools. Is that what I'm hearing you say?
That's exactly what you're hearing.
Okay, great. And there's an interesting model when they were trying to ramp up the health IT workforce for the country, and in particular partnerships with community colleges. So that's very interesting what you're saying. I love that idea too. Kelly?
If I had my magic wand, which was one of my favorite questions, is I think we need to really spend some time focusing on integrating behavioral health and primary care, because I think for this system to work, those two have to be working together. And as part of that, I think we need to focus on aligning incentives and measures, as Anne mentioned, because hospitals have different incentives than ACOs, than primary care, and we have to get those aligned so we can provide better care for the patient. And with the measures, they're all over the place too, so we need to standardize those. And last but not least is to really continue to help practice facilitators learn about and use transformation, change management, change fatigue. It's all about change and helping practices change. And so I think those are kind of the three areas I would focus on.
That's some big thinkers on the phone. That's great, Kelly. Let me ask you a couple of questions about that. So integrating behavioral health back into primary care, what would a practice facilitator, map that back for me to practice facilitator training and workforce development, what would you see a facilitator needing to know about those things right now?
Well, currently it's different languages, different icons. Practices have patients. Centers, which is behavioral health centers, have clients. And just how different the languages that are used and how they do business is so different. Practices have, 15, 20-minute appointments, maybe 30 and 40 appointments, and yet centers have 45 and 60-minute appointments. So it's just two separate cultures that are going to have to be trying to combine and work together and be integrated. I think it's going to be very important.
So a lot of policy issues, Bob and Jan and David, if you're listening in. Let me ask you, Kelly, also about change management. You said facilitators need to learn about change management. Are there any, like, 3 pearls that you could offer about what facilitators need to know about change management? If you could give them three pearls.
Number 1 is that change is hard. We, as humans, number 2, resist change. And what we're asking the practices to do is change. And so we continually have to focus on ways and what's in it for them and why make this change. And because healthcare is changing all the time, this is going to be one of the biggest skills that we, as an organization and a country and individuals, have to deal with. How do we adapt to and manage change without getting burned out?
Excellent. Kelly, thank you so much. I want to give the 3 of you a chance to react to each other. Anne or June or Kelly, do you have thoughts or reactions to what your colleagues shared? Or anything
well,
you'd
this
like
is
to add?
Anne. This is Anne, and I'll jump in. I thought the answers that the 3 of us gave to the first question, I just thought that it was great, and I would absolutely wholeheartedly agree to the other 2 answers that were given. And I think if you put those 3 areas together of, policy making, educational system redesign, and then, integrating behavioral health in it, I really think that might be our next, triple aim.
June or Kelly, any reactions or responses before I move on?
This is June, and I smiled when I heard the discussion about change and as areas of importance. And I will say that every single week when we talk about content, we are talking about change, because practice facilitators, that's at the heart of their practice. And again, policymakers, educational organizations just have not put enough emphasis on the concept of change and the importance. And perhaps that's one of the biggest attributes that a practice facilitator can bring to the practice, is how to move through change just a little easier.
Great. Thank you, guys. So I'm hearing a couple of things. One, that practices are changing all the time, and so facilitators may be a long-term resource to a practice rather than a short-term one, which I think is a thread that emerges frequently in these conversations. And also that policy has to get kind of its act together to be able to help practices and their facilitators succeed. Let me move now into a little bit more into the weeds. And one of the questions from our audience is the following, and any of the 3 of you might answer this. Which, if any, previous professional preparedness of your students do you find to be the best as it relates to learning and understanding the role of the facilitator? In other words, is it easier for a nurse or a PA or some other type of professional to learn and then become a practice facilitator? So that floor is open to the three of you.
Well, I'll answer this, but my perspective is different from the others in that, keep in mind, the people that I'm training are also the people that work for us. So when we hire them and train them, we're hoping to keep them for years to come. And my answer is going to be kind of lame, and I'm sorry to jump in with it, but life is the best teacher in all of this. And I think, Kelly's answer earlier of, the personality of the coach is key in working to their own style and those types of things. And I think, I don't know that there's a background. I know that I can tell you for each background they have what a great use we can make of it. But I think that there are some things that they're still going to have to largely compensate for. When we hire for positions, educational background is always very important. What can they use from that educational background to contribute to the team is great. So having a nurse on your team is wonderful because we're working in clinical outcomes, and they really can handle those conversations with the physicians that they like to really get into, debating the measures and those types of things. But I think, I come from a social work background. So my training in group dynamics and how people resist change and those types of things is huge in our approach to this. And so I think, all of it has strengths. I think the number one thing we look to hire for is creativity, is truly, can you shoot from the hip? Can you work in this? Can you go to this practice with a full agenda on your mind of what you think you're doing today and get there and be hit with something totally different and still make a good use of their time with you today? And so I think those are some skill sets that are a little softer, a little hard to wean out. And, how can we find those so the professional training piece becomes a key piece in it, but maybe not as much as your delivery in the practice?
Great, Ann. Thank you. Curiosity, I love that, and creativity. Kelly or June, do you have anything to add to what Ann said, or do you ditto it?
This is June.
This is Kelly, go ahead, June.
Oh, that's okay. I completely agree with Ann, and just might add, the only thing that I would add to that is the recognition by each facilitator of, just like with all of us, when they don't know, the important part is for them to have a community that they can turn to. And I think that all of us are trying to build that community so that they have people that they can go to outside of their own organization to maybe get some of these answers or have a different perspective.
Excellent. Kelly?
I think it's both answers are great, and I agree with them 100%. And even on our own coaching staff, we have, social workers, nurses, business people, MBAs, and it's all over the board. And we purposely did that because we need those variety of skills to make this happen. But the most important thing is the personality and the willingness to figure it out, problem solve, and the people skills to make it happen.
It reminds me, I used to work as a psychologist, and one of the things we talk about is Michelangelo's sculptures in Rome. And he said, I never create a sculpture, I just release what's in the stone. That's my work. The form's already there. And Ann, I'm hearing that a little bit in what you're saying, and also June and Kelly, that you take what people bring and then help leverage that to help the practices, in addition to adding many, many skills. So let me dig really deep in the weeds, and I'm particularly interested in this question because I'm struggling with this same issue right now at LANet, and I'm also working with AHRQ and the Mathematica team to develop a training module on it. So I'm very curious to hear the answers. How did each of your practice facilitators gain knowledge on electronic health records? How do you go about, what are those competencies, and how do you go about training them on it?
Well, so in North Carolina, we started this way back in the mid 2000s, and I think we gained it in a lot of very painful hair-pulling ways. And actually, we shared all of that hair pulling with HealthTeamWorks because we were kind of in this together back then. And it's much easier now to gain knowledge in electronic health records. Because of some of the standardization that has occurred, we can have a set of expectations for EHRs. Now they address it different. They all look different. They function different. But you can have an expectation of, let me go in here and see where I can find this. The best way to really do that is to hire staff that have worked in multiple settings prior to them coming to you, because they've probably worked in multiple different EHRs. And so I have some staff that have gone through their own implementations of 3 or 4 different EHR systems from working in different healthcare systems prior to even coming on to working with us. And so and I think healthcare is going to go like that. We tell rural providers all the time, when you're interviewing people, find someone who's worked in your EHR. They can help you and those types of things. So I think it's a piece of healthcare that we're going to start to really see and make use of.
Thank you, Ann. June or Kelly, anything to add to what Ann has said?
Yes, this is Kelly, and I think the biggest thing is that there are too many EHRs out there to be an expert in one or even more, unless that's your specific job. So as a practice facilitator, it's important that you know what questions to ask and know that there are resources available to the practice, whether it's an online form or the other companies who support those EHRs. And so I think that's a big thing as a coach. You got to make sure and get those population management reports out, but you can't get too deep into the woods. But it also depends on what your goals are that you're trying to achieve and what the expectations are of those.
The only thing that I might add about the IT piece, and we've stressed this, and recently it just became more apparent to me, is the integration of the person who's in charge of IT at a particular organization with the rest of the team, and to stress the importance for everyone and not to sort of isolate that person over in a corner, which some practices actually do, until they recognize how critical it is to make those IT individuals part of the team. And so I think that has been something that at least I've been stressing more recently, because it just became apparent to me. And I think, and I agree that no one is an expert in every one of these EHRs, but to help them understand some of the basis of what practices need in EHRs and how that particular piece of technology can assist or make it a little more challenging.
All right, so we have about 60 seconds left, so I'm going to ask for a very laser response to the following question. But I think it's an intriguing one, and it is, how do training programs help facilitators from different professional cultures communicate well with each other and with the clinicians and practice staff they work with? 3 lessons learned, Ann, 3 lessons learned, Kelly, 3 lessons learned, June.
One is, I think, when they're faced with their own gaps in knowledge when they're in a practice, they're so thankful that someone on their team is from another professional area and can help them with that. It's the IPE, it's the interdisciplinary professional education to a T. I mean, it's beautiful, and it should work better like that in all places in healthcare. So I think when you're in a practice and you're kind of put on the spot with things, when you have a gap in that knowledge, it really helps you to reach back to your team members, and I wish we could build that better in all aspects of healthcare.
Great, Ann. Thank you. One lesson learned from each of you. I'm sorry. Kelly.
I think the big thing is that your role is to be the resource. They were trained in medical, they went to medical school, nursing school, or whatever school to work in the field, but nobody had taught them how to do these practice transformation, quality improvement activities. And that's what we bring to the table, and that's our role, to help them work through this and deal and learn about change.
Great. Thanks. Kelly June?
So I'm going to build both on what Ann and Kelly is saying. Understanding the community that you're in and who the people are in the community outside of your practice facilitation colleagues who might be looked at as content experts, whether that be clinical or communication or quality improvement or how to put those graphs together. There are people in the community that can become partners. And so to me, that's one of the pieces that we should be stressing so that the practice facilitators become that hub, that resource that Kelly mentioned.
Well, I want to thank the three of you for your time and willingness to share all your knowledge and information, and then let the audience know that the case studies about these training programs, as well as case studies about practice facilitation programs that are considered exemplars, which these three certainly are all available on the AHRQ website, as well as the practice facilitation manual, which was authored with Cindy Brock and myself a couple of years ago, that has some very good training modules that you can access. And all of this work that we're doing right now, and even the information shared today by these speakers, are going to be going into a second set of training modules that will be available sometime in December, and Bob will talk to you about that a little bit more. So I'd like to go ahead and pass the floor back to AHRQ and to Bob and ask him to make some closing and summary comments.
Great. Thank you, Lindy. And first, let me just say, wow, fantastic presentations. That was a wonderful discussion. On behalf of AHRQ, I want to say thank you to all of our presenters, and especially to our special guests, Ann Lefebvre from North Carolina, June Levine from Millard Fillmore, and Kelly Boland from HealthTeamWorks. Thank you guys so much for joining us today. And thank you also for opening your doors to our interviewers as we looked deeper into your exemplary programs. And, you know, there's just no way I think I can do justice to summarize what we've heard today. Let me pick on a couple of things just to see what I heard and maybe a few obvious things. Well, first of all, sort of an obvious lesson perhaps that we've learned today is that different models can be successful. There are more than one way to train up practice facilitators who can provide services needed by primary care practices today. But having a strong mission, it sounds like all three of your organizations had a strong mission-focused, mission-driven curriculum that really tried to focus on the deliverables. Another sort of strong theme for me is that it's about relationship building as a skill not only for practice facilitators but also within the programs. And in terms of what that means is, that we find that they learn about community, and that a community of practice is required within the training process, but then connections with the community are important for practice facilitators to do their work well. We also heard a lot about change, change being the only constant, that practice facilitators are really specialists in change and change management, and in some ways their ability to adapt to those things is driven by their personality and their life skills and the backgrounds they bring. And I've heard these four themes come up, and one was about adaptability, one was about flexibility, one was about responsiveness, one was about creativity, and those four characteristics describe not only the training programs that we've heard about, but also describe the characteristics that you want to have in your practice facilitators. So it's great that they are sort of representative of each other. I also heard a little bit about identifying competencies as being important, that they need to be organic. They need to be responsive to what's going on in the community. Likewise, they have to be flexible and adaptable. That programs need to be innovative, and we heard three innovative models, and whether it's virtual or in person or a mix of those things or a boot camp. Love the idea of a boot camp in Colorado. That's exciting. All these things require the use of technology, engagement, staying in touch, and again, building that community of learning around practice facilitators. I think we've learned also about the importance of role modeling. I heard that from the instructors, the mentors, the preceptors need to encourage and support the trainees. Preceptorships, critical interactions outside the box people are comfortable with, those tandem visits, shadowing, all about relationships and building those relationships, and that's really critical. And sort of the last theme I heard a little bit about was about integration, and this is integration on many different levels. Integration in policy, reality-based policy making would be helpful. Integration within health professions education, and we see PFs as a connector for that. and Kelly very eloquently described integration about behavioral health into primary care and the challenges that rest there. So with that, those are just a few sort of general observations. Of the questions I've listed there on the summary slide, the last one, how will you use these models to develop your own programs and recruit and train new facilitators, or use them to help support primary care practices in your community, is a rhetorical one. And we'd love to hear from you. As Jay mentioned earlier, we have a primary care practice facilitation listserv. You'll get information on that about a minute. We'd love to hear your thoughts and observations. And with that, I'll wrap it up. And thank you again to everyone for your participation, and thanks to the audience for joining us today. So Jay, back to you.
Thanks, Bob, and thanks to everybody else who has offered their opinions and comments here on both virtually and, well, we're all virtual, I guess, but through the Q&A module and also through presenting their work or talking about their programs. I really appreciate all the efforts today. A couple things to think about going forward. Save the date. We're going to have another webinar on practice facilitation related questions, and I know there were a number of questions around the use of electronic health records and how practice facilitators learned about that, and our next webinar will focus in on how practice facilitators can support the meaningful use of electronic health records in supporting the PCMH, and registration details will be coming to you soon. For ongoing updates and more information about practice facilitation and for additional answers to the questions that we got here during the webinar that we were not able to get to today, I would encourage you to subscribe to the PF listserv, which you can do by sending an email to practicefacilitation@mathematica-mpr.com and just include subscribe in the subject heading, and you'll start getting those newsletters. And finally, the case studies that were presented today are available online already on the AHRQ website if you follow this link, and also are attached in one of the widgets down at the bottom of your screen. And so once again, just thank you all for your attendance today, and we look forward to seeing you again in the future. And this will conclude the webcast for today, but